Hello, I'm Dr. Jorge Campos from Vigo, Spain, and today we are going to talk about the socket seal technique. Today we are going to discuss many topics like what is a socket seal, why do we do socket seal, the biologic principles underlying this technique, the technical procedure, some history, cases of socket seal, and also a proximal approach of the socket seal. So in the beginning, what is a socket seal? Socket seal is a technique in which we extract a tooth, insert an implant, but we intentionally left the buccal slice of the root on the socket, as you can see here. And this is the socket seal. Why do we do this? Because as implantologists, we are always facing the problem on the buccal aspect about the bone. The stability of this bone, you can see these images, the difference between this and the next one is 5 years, so we are losing some bone and we can see the implant. And so we are always trying to get some bone on the buccal side. This scheme, this drawing, is not real. We are accustomed to things like this, but on the reality, which is the measure about the buccal bone. We know about this article of Mariano Sanz and many authors that they measure the buccal bone on the human being, and they realize that almost the 80%, between the 80 and 90%, is less than 1 millimeter thick. So we are talking about this lamina and how to preserve it when we do our implants. In this staining, we can see the composition of thick bone that forms the buccal aspect of our socket. We can see there is a dense bone, here are immature, and here you can see the mature bone. But you can see the osteons here, primary osteons, secondary osteons, and in the center we are going to see the Haversian canals. This is important. Let's talk about Botticelli, but not Sandro Botticelli. We are going to talk about Daniel Botticelli, that in 2004 he wrote a paper about the hard tissue alterations following immediate implant placement in extraction sites with Berglund and Dr. Linde. And he found that putting our implant does not prevent and does not maintain bone. You can see here that in these surgeries they extract the teeth, insert the implant, but they are raising flaps. You see? Raising flaps. And after 4 or 5 months, you can see the resorption that they had. So, let's talk about the biologic principles of the socket seal. We have to talk about the bone vascularization. The bone vascularization is through bone marrow and the periosteum. You see, when we raise a flap, there is blood here that is the interruption of the periosteum supplying vascularization to the bone. But it's worse when we have a socket of a teeth that we extract, because we raise a flap, we take the vascularization of the periosteum. We extract the tooth, and there is not more any periodontum. And you can see that there is no bone marrow on the buccal part of the socket. So it's normal that if we do the extraction with a flap, we will have always a resorption vertically and horizontally, especially on the buccal aspect of the alveolar process. And you can see on the forums that many people, after looking some CBCT, they say, oh, it looks like there is no buccal plate, and there is not at all. And what happened? It happened that we had interrupted the vascularization of the periosteum. You can see here that the periosteum is the umbilical cord of the bone. Let's talk about this man, Arthur van Leeuwenhoek. He was the one who invented the microscope. And this is a drawing of Arthur van Leeuwenhoek about bone. It's the first 3D image of the bone in 1677, more or less. But a friend of him, Clopton Havers, studied more the bone, and he described the osteons, and he said that in the center of the osteons there is a canal, and he put his name, the Havers canals. This canal has an artery and a vein, but these canals are important, but more important are the Volkmann's canals that connect to Haversian canals, because this Volkmann goes to the outside of the bone where the periosteum is. So now we understand that it is very important to maintain the fluid movement in the compact bone, because the Volkmann canals from the marrow cavity, they are very connected, and the blood supply comes from the periosteum. As you can see here in an old article about a bone of a monkey, they made a microradiograph, and you can see, look at this, the Volkmann canals going out to the periosteum. So, also, when we extract a tooth, we made 3 different changes in the gingiva. First of all, the gingival vascularization is different because it comes from periosteum, from the bone, and from the PDL. So this part is more vascularized. But when you have an implant, we don't have the PDL blood supply. Second, we lose dentogingival fibers that maintains the gingiva. And third, the connective tissue surrounding the implants has less fibroblasts, so it's more like a scar tissue. So this is a big difference that we transform our gingiva when we extract the tooth. Also, we have to understand, in this article of 2007 of Dr. Salama and Garber, the advantages of the root submergence, because they found that this technique maintains the natural attachment apparatus of the tooth in the pontic site, that makes a complete preservation of the alveolar bone frame. So, if we maintain the root, the bone is just like it was. You can see in these examples, when we left this root, there is a stable anatomy on the thumb after more than 2 years. Also, what happens when an implant touches a tooth, a root? Let's say the cementum layer in the implant surface with inserting collagen fibers. So that it is interesting that when the implant touches, you can see that the cement reacts and lays over the surface of our implant. So, with this in mind, we come to 2010, and Dr. Hürzeler, Otto Thur, and his equipment, they wrote this article in which they put in a beagle dog an implant and they extract one part of the distal root, but they emisected the fragment and the root was retained 1 mm coronal to the buccal bone plate. A titanium implant was placed lingual to that root, either with or without contact. This is important because it makes no difference. We can see now the histology. So, all four implants were perfectly integrated and the tooth fragment was attached to the buccal bone plate by a physiological periodontal ligament. But most important is this. On the lingual side, this is what we all have curiosity. What happens between the root and the implant? Nuliform cementum could be detected. In the areas where the implant was placed into the fragment, nuliform cementum was demonstrated directly on the implant surface. Conclusions: retaining the buccal aspect of the root during implant placing does not appear to interfere with the osseointegration and may be beneficial in preserving the buccal bone plate. Wow, this changed our lives because you can see here, this is the slice, the buccal slice of the root, and in contact, you can see this image. So there is dentin. Here a thin layer of new cementum. Also, when we magnify this relationship, when it's in contact, you can see that the surface of the implant also integrates in this new cement that is in some part with the presence of cementosita here. So, how do we do the indications? We have to have healthy and stable roots. Buccal bone attached to the root because the shield is to maintain the buccal bone. Buccal gingival pocket normal. Gingival level similar to the neighbor teeth. We are not going to do a socket shield in cases like this. Healthy gum tissues and no vertical cracks or fractures of the teeth. Contraindications, almost just the opposite: mobile and loose roots, deep contaminated pockets, active infection, high-level gingival contour, and cracked tooth. Okay, let's see the technical procedure. First, the horizontal cut. Second, the mesiodistal split. I'm doing this with high-speed burr and refrigeration. We have the horizontal cut 1 or 2 millimeters above the gingiva, just to keep it healthy. Then we cut mesiodistal, and then we are going to show how we do this and extract the lingual portion. You can see here another example, the mesiodistal cut, and then we are very carefully extracting the lingual part, the lingual root, in this case the palatine root of a bicuspid. Here another example of a bicuspid. And then we change this, we are thinning the buccal slice. But the problem is with a single rooted teeth, because it's not like a bicuspid that we can remove easily the palatal root. On a canine, for example, or an incisor, we have to cut with a very long burr till the apex, just to obtain the whole lingual part. With periotome, an elevator, we lose from mesial to distal, not making, avoiding to put inside the gap, because we don't want to get loose the buccal aspect. And now there is another thing, the edge of the shield. Once we have cut the root, we have the buccal part. And we can have the 4 levels, more or less. A supragingival level of the shield, we don't want it because we want to maintain, for aesthetics, we don't want to have a shield so high. Here you can see an apical junction epithelium. It's an interesting level. A connective tissue level that is important, and the crestal bone level. In this case, we are losing dentogingival fibers, but here we prefer to do this because we have some dentogingival fibers. In this case, we don't have. And subcrestal, we also don't want because we are losing attachment, we are losing bone. So here we can do, you can see that we are protecting the gum, the sulcus. We are putting some instrument inside, and with a round diamond burr, we are grinding this part of the socket shield here, and then inside the sulcus we prepare with a burr like this, the inner part, like if we were preparing for an abutment, and then we thin a little the inner part of the shield with a diamond burr like this, always at high speed and complete refrigeration. You can see here the implant and the shield. This is the provisional that we put with a PRF. You can see after 4 days the tissues, and after 6 days the quality of the cicatrization. Let's say that is almost like ideal case to have this kind of cicatrization. The implant shield relationship may be in contact, close, or completely separated. We've done different cases and we found no difference in maintaining the buccal aspect of the alveolar process. I'm going to show you case 1 with a hopeless bicuspid with a horizontal fracture. Let's see a video. Now we're doing the mesiodistal cut. In a bicuspid it's easy because there is a buccal and a palatal root, so it's easy to cut, and then with the periotome we extract the palatal root with an elevator, and then we cut, we extract. Then with a stent we prepare the position of the implant, and then we continue as normally. You can see we are preparing the socket, the implant socket. Now we are preparing the edge of the shield. We are the insertion of an implant, a very nice implant, and we have good torque. So we do here the one abutment one time technique, and we are putting here, you can see the relation of the implant and the socket, and then we put a cemented crown. Okay, this is the case. You can see all the steps in which we cut. We extract the palatal root, then we prepare the socket shield, the implant insertion, and then we put the abutment, the relation with abutment. We prepare to do the one abutment one time, and this is the provisional crown with the PRF. The healing 1 week is excellent. Here you can see the texture, the superimposition of the root, you can see here. After 3 months, and then we prepare a crown. Then you can see here we're checking all the steps. This is what we found when we removed the provisional crown, a complete seal of the abutment. And we made the impression as a normal tooth to fabricate the metal ceramic crown. You see the contour of the alveolar process that is very nice. So this is the result, and if we do the pink aesthetic score of Pure Hartsfeld, we are going to see that here we have all the different aspects: the mesial papilla, the distal papilla, the level, the contour, the alveolar contour, the color of the gum, and the texture. So these are very nice results that made me enthusiastic about this technique. And you can see on the CBCT image that we have a 2 millimeter of buccal wall. Here you can see the root fragment. 7 months post-operative, the tissues continue to be very nice. This is what we don't want to have: buccal resorption. This implant was put 3 years ago, and now the patient says, this is a little bit gray and dark, and this didn't happen when they first put the implant. This is because this is the normal reaction of the bone after 3 or 4 years. Case number 2. In this case, we did the socket seal, but we didn't have a high insertion torque, so we could not do immediate loading. We were very close to the sinus. This patient had extreme bruxism, so we extract the palatal root, we measure just to see the length of our implant, and we put, you see, before and after the preparation, and with the implant inserted, you can see this is important. We want to preserve this wall, and we did a special customized abutment with torque, 20 Newton torque and PRF, and you can see after a week there is a nice healing. The 3 steps, the implant and the shield. 4 months, and when we took the impressions, we removed this abutment, and which is what we found: nice emergency profile. You can see the difference between a socket shield technique and a normal implant on a healed bone. The healing, maintaining the buccal aspect, and the final crown the day of the insertion. Before and after, we are maintaining the level, the quality of the tissues, the papilla. So, but we can do Socket shield on different cases in immediate load full arch or state load full arch. As cases like this, we are going to put a full arch rehabilitation, but we have two nice canines that we are going to maintain. So we cut horizontally, we took the lingual part, put the implant, and we left staged, not loaded. And after 3 months, this is what we found. On the other side, after 3 months, it was completely covered. But then we look for the implant, and this is the aspect of the socket shield implant. And we can do here a comparison because in one implant we did with autologous bone and biomaterial and a membrane a regeneration. And after 4 months, you can see the regeneration is very poor, but the socket shield implant has a better width. You can see there the socket shield implant and the normal implant with the GPR here. Another case of full arch, but with immediate load on SS technique. Here we cut as always horizontally, vertically, and then we extract the lingual part, inserting the implant. You can see there we put some PRF on the gap. After 24 hours, this is the emergency profile that we have before the insertion of the immediate prosthesis, screw prosthesis. You can see here the image. 24 hours, and here is the prosthesis on place, and a week after it's completely healed. We have a crown, a fractured teeth, a hopeless root. In this case we did it with very long canine. We had problems to get the lingual part, and in this case we left because it was done on a course, and a doctor insert the implant, but we didn't thin the socket shield. So when we finally inserted the implant, we had a green branch fracture of the buccal wall of the socket, and we did a suture, and after 4 months there is stable. There is no problem because this buccal wall is with the PDL attached to the socket shield, and also is with the periodontium, periosteum, I think, attached to the bone. Well, but in 2013, again, Dr. Hürzeler and Otto Thur, they say, is it necessary to have the whole shield to maintain the buccal bone? Or can we do it the half socket shield to support the vascularization of our buccal bone? So they did this in 4 beagle dogs. They cut the distal root of a premolar, and then they do the socket shield, extract the lingual, and the vestibular part they cut in 2 and extract one part of the socket shield. And look at this, what we have. Again, that there is no osteoclastic remodeling of the coronal part of the buccal plate on between the root and the bone here, and on the lingual part there is bone in connection with the root and the implant. And this is the extracted shield, the buccal, and this is the remaining buccal shield, the half. And you can see that it's bone in the gap. Why this is important? Because many hopeless teeth are because there is a vertical fracture that makes a gap inside and makes a problem in the gingiva through this crack. And so they did this in the patient. They prepare the socket shield and they make a groove, and then they insert an implant, and they have a nice reaction with this provisional in place with a socket shield but with a groove in the middle. This is the superposition between before and after, and you can see that in red there is a loss of 1.67 millimeters, and in the blue is the less loss of the volume. But what about the hardest case on the aesthetic zone? That means two implants side by side. What can we do here? Because of the length of the papilla compared to the contralateral side. Well, Dr. Joseph Kahn in 2013, he described the proximal socket shield, because he had this case in which there is an implant and there is a tooth, and the papilla is supported by this interproximal bone peak. But if we extract this root of this fractured teeth, we will lose this bone peak and we will lose this papilla. So he did a vertical socket shield, and he kept the distal part of the central incisor just to maintain, you can hear, the inter-implant papilla. And this is the result. That is well maintained after 1 year, the papilla. You can see before and after. So the proximal socket shield has the same quality of the buccal socket shield. Here there is a case of a double socket shield, two teeth and a proximal socket shield between them. There is a canine and a bicuspid. We did the socket shield, but on the canine we cut like a T cut, horizontal and perpendicular, and we extract this part, and this is the buccal shield, and this is the proximal shield. So we left there the distal part of the canine here. We are thinning as we show it before the shield. And this is the relation between the implants. There is a big gap between the implants and the shield. And we made a customized abutment, as you can see here, with composite, and we put some biomaterial. And here you can see the proximal shield. Oh, and there's a gutta percha. Here you can see that I hope that it won't make any problem, but I didn't have by now any problem left in some gutta percha on the shield. And you can see here there is a nice healing, nice texture, After 40 days, the texture of the gingiva is nice and the papilla is maintained like this. Can we do a socket seal on an orthodontic extruded root? This is the case in which we have a lateral incisor with a problem because of a fracture. This is a crown, and we are going to insert an implant, but we have problems with the papilla. You can see here this line, and we extruded the root orthodontically just to have a better bone, a peak bone. You can see from here to here, and we, after extruding the root, you can see here that there is bone here, and we extruded the root. And then the problem was if we were able to extract the crown and this screw that was cemented on the root without extracting the whole root. So we can, and we make the socket shield, and we prepare and put the implant, as you can see, and maintain with a good torquing of insertion. And you can see the relation between the socket shield, and we put a cemented crown 3 days after, 1 month after. So this is healing now, and the gingiva has good texture and color. And another case is, can we do a socket shield, but can we extract the apex of the tooth? Because here we have a bicuspid with a problem on the apex of the buccal root. So we just need the most coronal part of the root, and we cut the palatal root, and on the buccal part we made an incision, an aesthetic flap. You can see here, this is the augmentation. Here is the apex with good aperture. So we extracted, then we inserted the implant, but in this part there is the socket shield, and we do some regeneration, membrane and PRF, and also we did immediate deload because we have a good torque insertion. And here we have the socket, and this is in that place, in the ridge, the implant was, the tooth was extracted many years ago. And this is the healing after 25 days. So we talk about today about the technique, about the biological principles, and many cases of the possibilities of this technique. Hope you like it, and this is all. Thank you very much.